Hello, and welcome to the very special edition of the Lipid Insights podcast. I'm coming to you live from the MNLA Fall 2025 Clinical Lipid Update in beautiful Scottsdale, Arizona. I'm your host, Dr. Peter Jones. I couldn't be more excited about being here to be surrounded by some of the brightest and most passionate professionals in our field. If you're tuning in from across the country, this podcast is your backstage pass to the ideas, the conversations, and the energy that make the CLU experience unforgettable. We've got a fantastic discussion scheduled today, so let's dive into the spirit of the MNLA Fall CLU. Today, I'm very fortunate to have with me Dr. Casey Berman. She is a clinical assistant professor in the Department of Pediatric Endocrinology at NYU Langone Health. Clinically, is at NYU's Pediatric Obesity Clinic, which is a multidisciplinary center involving lifestyle interventions, pharmacotherapy, and bariatric surgery. So welcome, Dr. Berman.
Thank you so much. I'm honored to be here today. Thank you for including me on your podcast. And let's get started.
Well, let's first of all, your CV is long enough that I don't need to be reading it. What I want the audience to know is, what do you do every day? I mean, what does a pediatric obesity specialist do every day?
Good question. So I see a variety of pediatric endocrinologic disorders, but a big portion of what I do is obesity. And it's a wide age range, starting really as young as less than a year old, so infants, all the way up to young adults who are in their early 20s. And I really am a part of their care in a whole spectrum, from identifying what level of obesity they are, how do we start management, what kind of management do we do. I'm kind of part of that from the beginning, and then follow these kids for a long time with the help of some other care providers.
Yeah, so it's a multidisciplinary approach to get this thing accomplished, isn't it?
It's definitely a multidisciplinary approach. It takes a team to really give comprehensive care to these kids. And I am lucky that I work at a center with really great support. So I'm now the medical director of the Pediatric Obesity Metabolic Program. And that includes physicians, nutritionists, social workers, psychologists, and a bariatric surgeon, so that we can all see these patients together and provide the best care.
Oh, that is awesome. Well, I mean, as I say, it's interesting that we've got a specialist like you talking about pediatric obesity, and we're here at the National Lipid Association meeting. And I think that this is important to understand that the earlier we identify some of the components that deal with overall cardiovascular health, the better we can intervene earlier and have long-term better outcomes. So what is the prevalence of pediatric obesity? Where does it stand now?
Great question. So there was a study that came out in 2024, so recently, looking at the prevalence of pediatric obesity over the past 20 years. And it showed that there's been a linear increase in the prevalence over that time. And even starting as young as 5 years old, the prevalence is as high as about 15%. And then by young adulthood or late adolescence, it's about almost a third of the population. And if you also include those who are overweight and obese, then the stats are even higher. It's 40 to 50% of the pediatric population. So this is definitely on the rise. And by 2050, it's projected to be much higher than it is now. So I think now is the time to really identify this and start approaching it, like you said, early on before, these comorbidities arise. And there's been a lot of studies that have shown that pediatric obesity is not the same as adult obesity, and kids develop comorbidities early and they progress really rapidly. So there was a study looking at kind of in kids who develop type 2 diabetes, their 15-year prevalence of then, or 15-year risk of them developing other comorbidities was extremely high. And we know that childhood obesity is linked to adult morbidity and mortality. So it's really important to start addressing this really when they're young before these things develop.
I mean, is there a different BMI measurement tool in pediatrics and adolescents than there are in adults?
Mm-hmm. There is. So in pediatrics, we use the growth chart and we look at their BMI percentile. So in kids who are aged 2 years to 20 years, we are saying that over the 85th percentile for BMI is overweight and over the 95th percentile is obese. But then we actually are stratifying it further and we're defining severe obesity. So we look to see what percent they are over the 95th percentile. So there's actually a separate growth chart that then has lines above the 95th percentile. And if you're up 120% of the 95th or higher, you're class 2. And if you're 140% of the 95th or higher, you're class 3. And that stratification is really important because we use that to guide our intervention.
Your interventions, okay. Mm-hmm. Well, there's always obesity is you eat too much and you don't exercise enough. I mean, is that the same set of risk factors in kids as it is in adults? It's dietary and sedentary lifestyle?
Great question. So I think it's really multifactorial in kids. So certainly the lifestyle is a huge factor in terms of, what they're eating every day, the nutrient content of their food and how active they are. But I think it's a lot more complex than that. So we've definitely identified that obesity is a condition. There's a really strong familial component. And we've started to really try to identify the genes that are at play. So we're doing a free testing by a pharmaceutical company that identifies specific genes that are involved in the MC4 pathway in the hypothalamus. And that's the pathway that regulates your hunger and satiety and metabolism. So often I'll see kids that come in with just really, really severe hyperphagia where they can't eat lunch in the same room as their peers because they're taking their peers' food. So really uncontrolled hyperphagia that's more than just, the normal hunger you see. And so we're now trying to identify genes that are really regulating these hunger mechanisms to try to more personalize our approach, because a lot of this is innate in these kids. It's not necessarily all, external environmental. So I think genetics is a big part of it. And even without these specific MC4 pathway genes, we see that, the grandparents, the parents, the kids, they've all had obesity. A lot of the family members have had bariatric surgery, and that's despite them really, really trying to have lifestyle intervention. So I think that it's a bigger picture here.
Yeah, it's probably polygenic too. It's in most cases, right?
Exactly.
Is there a difference in the incidence of obesity based on ethnicity?
So good question. It's been shown that obesity disproportionately affects the lower sociodemographic groups. And I think part of that is more Hispanic ethnicity. And it's hard to say if the ethnicity itself is what's at play. I think likely that there's a genetic component in that, but a lot of it's a socioeconomic, and that's because of a lot of community factors. So, for example, a lot of neighborhoods are food deserts where there's just not affordable foods available for families. There's not a lot of safe outdoor places for kids to be physically active. And that is all kind of in the sociodemographic realm. And then also just, the education that the families have in terms of the parents' own nutrition education. What is their mealtime routines? Are they sitting at a meal together? Are the kids, on watching TV on their iPads, eating and kind of having mindless eating? So there's a lot of kind of external factors that are involved in the family unit and then in the broader community.
Yeah. Just a brief comment about dietary factors. Does ultra-processed food play more of a role in this than other type of foods?
Great question. So definitely. There are, I think the commercial food industry plays a really large role in the obesity epidemic right now. Food companies are definitely marketing foods that are ultra processed, and ultra processed means that they have added ingredients such as added sugar, whether that's high fructose corn syrup or a lot of saturated fats. And these foods really are being marketed to infants. It's in the formulas and the milks and the products that are weaning from breast milks. Right. And a lot of people don't know that these formulas or these milks or these baby foods have such a high sugar content. And there's been studies that have shown how those types of foods can alter the taste buds in babies and then kind of predispose them to a preference for sugar sweetened beverages and foods later on and higher rates of obesity later on. So there's a lot of research and a lot of labs that are looking at the content of different milks and different baby foods to try to kind of curb that because it does start at such an early age.
Yeah, we just want to tell parents to not start their kids going to Taco Bell and Chick-fil-A and McDonald's too early in life, right? It's not the best. What role does you say you have a psychologist in the multidisciplinary group? In children, I mean, it's hard enough to not be bullied about things when they start to grow up, and obesity has got to be one of those things there. Well, how does mental health play a role in some of this?
Mental health plays a huge role in this. So I think that it's been shown in studies that in kids who do have obesity, they're at risk for a lot of mental health concerns. There's some studies that show pretty high rates of disordered eating in that group, a lot of binge eating, loss of control eating, as high as like 18% of obese populations have been identified to have those in the kind of youth and adolescence, but also it really can affect self-esteem, self-confidence, especially when bullying is such a tough thing in these kind of adolescent years. And a lot of times too, their sleep can be affected. If they have obstructive sleep apnea, that can lead to a lot of daytime fatigue and just difficulties with that, with their performance in school. So I think that having a mental health provider on board is really important. And it's been recommended by the Pediatric Endocrine Society, I believe, that kids who are living with obesity should be screened routinely for mental health concerns because of the risk.
I think that's a great idea. And I assume that also there's by genetic predisposition or others with obesity, that you do get a lot of the typical adult comorbidities you see with obesity, such as type 2 diabetes, MASLD, liver fat, dyslipidemia, hypertension, all that, right?
Mm-hmm. Yes. So all of these comorbidities also affect children, and they do so early on, and they progress rapidly. So there was actually a study called the Today 2 trial that showed that in kids who have type 2, they have more rapid progression of the disease, and they also have more rapid decline of their beta cells of their pancreas. Wow. So, we were taught that in people with type 2, they generally don't develop diabetic ketoacidosis, which is a serious condition that type 1 diabetes patients can sometimes get because their pancreas isn't making insulin. And in type 2, theoretically, their pancreas should make insulin. Right. But because the aggressiveness of the disease and because kids with type 2 have decline in their beta cells, they actually can have insulinopenia where their pancreas burns out, they can't make insulin. And we have kids with type 2 getting admitted to the hospital really, really sick from DKA because of, the severity of their type 2 diabetes. So I think that comorbidities are real, and it's our job to try to prevent them before they progress to that point.
Oh, wow. That's amazing. Mm-hmm. Well, now that we've sort of identified the problem and we okay, you're obese and I've got this group of I need nutrition and lifestyle interventions. I need psychological counseling. All those things are going to be important. But getting down to significant obesity, maybe with some of these comorbidities, what therapeutic interventions do we have? We have a presentation here about how to use GLP-1 receptor agonists in adults. Mm-hmm. Are they an option? Are they approved by the FDA for use in pediatric obesity?
Mm-hmm. They are. So this has been very exciting in the last few years. We've had some new approvals because I will say that the management has of pediatric obesity has been very limited due to lack of data and lack of FDA-approved medications. So in 2020 was the first time that a GLP-1 was approved for pediatrics, and it's liraglutide, which is a daily injection.
Right.
It was approved for age 12 and up. And then soon following, the weekly GLP-1 semaglutide, branded as Wegovy, was approved in 2022.
Same age?
Same age, 12 and up. So that was really exciting because daily injection is a little bit hard to swallow. I think families are a little resistant to start that. But then once we had the option for the weekly injection, then that really was a game changer in the field. And so I will say, although semaglutide is approved for 12 and up, that does not mean that insurance companies will cover it 12 and up.
Oh boy.
So that is a huge barrier. And it's different in every state. I was practicing in California, and GLP-1s were approved for publicly insured kids, which was excellent because a lot of times the lower sociodemographic kids are the ones who need it the most, and they're able to get it in California. Whereas now I'm in New York, and it is kind of an absolute decline every time we try to get a GLP-1 for a publicly insured patient. So that's been very tough and limits. But I will say, when we are able to use them, they're really life-changing in these kids.
Are they tolerated as well? Do they have any special issues with adolescents as opposed to adults in their results and percent weight change and tolerability?
Yeah, so they definitely have been shown in studies and in my clinical experience to have as good a benefit as in adults. And actually, some studies have hinted that they may even have more of an effect on weight loss than in adults. So studies show up to 15%, even 20% of weight loss in some patients. And in terms of the side effect profile, it's mostly gastrointestinal side effects, same with adults. And I would say it's mostly during the up titration.
Right.
And what's interesting is that the recommended dose for treating a child is the same recommended dose as treating an adult. So one would think, are they having more side effects? They're using the same dose that an adult is using. I think that, even though it's recommended, let's say for Wegovy, to go up to 2.4 milligrams, I and most endocrinologists really individualize it because some kids are much larger responders than others. And so in some, we get to 0.5 milligram. I have a patient on 0.5 milligram who lost 60 pounds.
Wow.
So we don't have to go to the full dose.
Right.
And so I think it's really, finding the most effective dose with the least side effects. And that's where we settle.
Yeah, to ensure longer term compliance and all that. Yeah, I think that's
Exactly.
amazing. Do you think that the dual agonist, tirzepatide, is it going to be up for approval in adolescents?
Yeah, so we have been waiting for the approval of tirzepatide because that's the dual agonist. So it targets GLP-1 and GIP-1. And in adults, as you know, it's shown to have improved efficacy compared to just the GLP-1 alone and less side effects. So we have been waiting because since it's not approved, even if we wanted to try off-label, it's really not getting covered by insurance. And there's actually new data hot off the press that have shown the impact of tirzepatide in youth with type 2 diabetes.
Oh.
And it showed really positive data in terms of decrease in A1C, which was the primary outcome, but also in a lot of weight-related variables. So it looked at the BMI standard deviation score, the waist circumference, the effect on lipids, and all of the results were really positive. And the safety and side effect profile was also encouraging. It showed that it was similar to that seen in adults, and it's similar to that seen in GLP-1s in kids. So basically, all really encouraging. And I think that a FDA approval for tirzepatide in type 2 diabetes in youth is hopefully on the horizon. So the next step is getting that approved for kids for obesity who don't have diabetes. And there is a study ongoing looking at that.
Wow.
So that's next.
So that's great. It's good to know that there's continuing focus on this important patient population to make sure that they get what they need. And again, earlier interventions prevents long-term complications, not just from other end organ damage, but also hopefully cardiovascular disease and other things decades down the road. So I think that's important. Last thing I want to get to is, we have a underuse, I think, of bariatric surgery in adults. Is bariatric surgery used in adolescents?
It is. So bariatric surgery is recommended by the American Academy of Pediatrics to be considered if kids are 13 years of age and older, and they have either class 2 obesity with a comorbidity. So class 2 is considered severe obesity with a comorbidity, or if they just have class 3 obesity alone. And so the American Academy of Pediatrics came out with these new guidelines in 2023, which is what most pediatric endocrinologists are really using right now. And they are, I would say, the most aggressive guidelines in terms of intervening, because they've identified the chronicity of childhood obesity and the risk of the comorbidities. So, that's what we're really using right now. And bariatric surgery is available for 13 and older. That's what our center is doing right now. We'll have consults for youth who are 12 years old, but we wouldn't do the surgery until they're 13. That being said, I wouldn't say the majority of our patients are pursuing surgery. It's definitely, a big decision. It's obviously it's a big intervention. And I think the big thing to consider is that you need a lot of discipline leading up to the surgery and after the surgery. They have to be on a liquid diet for a few weeks. And especially these kids who have hyperphagia or, disordered eating with binge eating, it could be risky if they're going to have a hard time following those guidelines. And that's another reason why we really bring in our psychologists, our social workers, so we can get a really thorough assessment of them before they commit to this intervention. And then we can also have a lot of support in those weeks and months following the surgery. But the outcomes are unbelievable.
Yeah, I can imagine they are, because they usually are in adults as well. Do they do Roux-en-Y's laparoscopically or whatever in the kids like to do in adults?
Yeah, so the American Academy of Pediatric recommendations say to consider either the Roux-en-Y laparoscopic bypass or the vertical sleeve gastrectomy. And it has been shown that the vertical sleeve gastrectomy has less side effects.
Okay.
So that is really the number one recommended technique, and that's the only one that we do at our center.
Okay. I think that sounds great. And the last thing I'd say is that while the GLP-1s have a lot of excitement, it sounds like that they work as well in kids and tolerable as they do in adults, we still end up with the challenge of long-term compliance. So they go off to college and all this kind of stuff. And are they going to continue to follow what they need to now that they're out of the house and on their own? And what do you find about that, the long-term compliance?
Yeah, I think that's kind of a important thing to think about and an important conversation to have with these families when we're starting these medicines, because obesity is thought of as a chronic condition. Therefore, when we start these medicines, we have to have the real conversation that they'll likely be on them for a long period of time, if, many years. And if we stop them, then there's risk of the obesity returning. And, I do think, though, that we're often starting them in teenagers who, have trouble, they don't really know what are the nutritious things to eat. They don't really know what should a portion size be. They are kind of gaining this knowledge. And so I think that putting them on these medicines allows them to have the self-control to really learn, like, this is what is an appropriate portion. This is what I need to do to, maintain this healthy weight, so that maybe later on they can continue making good decisions that they've learned about. And I think that, it's a multidisciplinary team. So it's not just me seeing them, it's a nutritionist seeing them. It's a nurse seeing them that's following up with them. And so we're trying to give them the information they need to stay adherent and stay on track once they're kind of spreading their wings and leaving for college and being more independent.
Well, that's the other thing too, is that in pediatrics, you end up bringing these kids up to adulthood, and then you sort of have to pass them on to adult medicine care. So how does that work out? Where do you get them when they go off to college and they start being independent? You say, okay, I'm not your doctor anymore. Where do they go? Who sees them?
Great question. So I will say that we're pretty flexible, and we pediatric endocrinologists at our program have a hard time saying goodbye. So we'll often follow them through college until their insurance will allow them to see us. And then we're lucky that we're at a medical center that has a good adult endocrinology and metabolism center as well. So we often will really work with them to make that transition more seamless. And often, I'll start having the conversation to reach out to the adult center, make an appointment. But if they don't have something for 6 months out, I'll continue to follow them until I've confirmed that they have that appointment lined up. So we try to make that transition as seamless as possible, because that gap in care could really be detrimental to, their progress. So it's nice that I'm at a comprehensive center where we have that ability. And I think that us pediatricians like to hold on to them as long as we can.
Yeah, I can understand that. With that handoff is always difficult for you, but it's also challenging for the patient to find the right care that they need to continue with their long-term strategy, and find somebody who also is smart enough and has the other, multidisciplinary approach to help them as young adults to continue to be successful. So I think that's a very important part of this. Wow, this is so amazing what you've discussed with us today. And I know you're going to be teaching our lipid specialists and those who are in cardiovascular health improvement to learn more about what they need to do, particularly if they're the ones that have to accept these patients out of pediatric care, how they can be special in their long-term management. So listen, Dr. Berman, thank you so much for being with us. I really appreciate you joining us today on this podcast, and I hope everybody else enjoyed learning today from us. Thank you.
Thank you so much for having me. Bye, guys.